Form in the Valley, which is also available to read in European Stroke Journal. Valeria.
Thank you. Thank you both for your great support, and I cannot do else than echo Daniel and Wim for the support from Professor Ken Lees. I think that without him this would not have been possible to present today the guidelines and have the simultaneous publication. These are our disclosures. You find them on the paper. As you heard before, this is a group effort, and I can tell you this, especially for me, this was a great group effort. I should have been here with my co-chair, Christian Prestipino, who is the cardiologist of our group, but he had unfortunately other commitments. But you see the whole group here, and we worked very hard. Just one word regarding Lars Sondergaard, because you will find it on the disclosure. Lars started with us when he was still working at the University of Denmark, but then he moved to industry and he was not involved. Now he's working with Abbott, which is clearly a conflict of interest, but he was not involved in the voting. So this is for us we want to be very clear about this for the transparency of the guidelines. So we divided this guideline in 3 topics. One is the diagnosis. And we did not really work too much on the update or the workup of cryptogenic stroke, because we felt it was not really the question for our guidelines. We focus directly when we have done. So the journey starts when we have excluded other causes and we think of a PFO. And so we, in order to make everything more easy, because ESO guidelines are rigorous, but sometimes can be a little bit not so digestive for clinicians. So we put diagnostic in an overarching question. So which diagnostic test should be used to detect PFO-related right-to-left shunt in patient with cryptogenic stroke? And then we will face the singular the singular PICO question. Then we had the chapter about treatment, which is the most challenging chapter, and about post-procedural management, because we see more and more patients after PFO closure. So regarding diagnosis, as I said, overarching question, but clearly you need to be rigorous, and GRADE gives you, and this was clearly stated by Terence Quinn and Diana, that you will not find, and I worked also with other guidelines with the cardiology, the European Society of Cardiology, very fancy, very straightforward, but less the scientific. Sometimes I had to really say, but you have to select, you have to be more rigorous. There's a meta-analysis. So I think this is absolutely the way to go to be scientifically credible. So the first PICO question was, in patient with cryptogenic stroke, what is the diagnostic performance of TCD compared to transesophageal echography, using it as a conventional reference? Before starting these guidelines, I was sure that transesophageal echography was a gold standard. In reality, I had to discover that it's not like this. So you see, doing guidelines, and this is, I invite also young people who have a more flexible brain than me to do guidelines, because you learn very important concept that you give for granted. PICO 2, the diagnostic performance, transthoracic echocardiogram versus transesophageal echocardium for identifying right to left shunt. PICO 3, the diagnostic performance of TCD, if the diagnostic performance of TCD is superior to TEE to screen PFO-related right-to-left shunt using transesophageal echocardiogram as conventional reference. You can imagine doing all this singular PICO question. It was not possible to find a consensus, and the evidence-based recommendation for PICO 1, 1.1, 1.2, and 1.3, that in patient without an obvious cause of stroke, there's a continued uncertainty over the most accurate diagnostic approach for detecting any right-to-left shunt because of the lack of a proper gold standard. And therefore, we are unable to give an evidence recommendation. Quality of evidence low, strength of recommendation. So this is something that you say, you're right, but we need to go forward. Therefore, we formulate the expert consensus statement. As there is no technique that can be considered a gold standard, we advise, and I think this is the most pragmatic approach that we could find, locally agreed diagnostic algorithm to using their available technique, TCD, TEE, TEO, to diagnose right-to-left shunt, keeping into consideration that TCD is suggested when TEE or TOE are inconclusive. This is a vote for 9 in 9. So, for example, I can tell you, in my clinic, we have currently there's only one operator doing TCD in diagnostic. When he's not available, we use a TEE, and we use TOE as a control. In light of the available data, second expert consensus statement on diagnosis, the working group acknowledge that TCD demonstrate superior sensitivity relative to TEE in right-to-left screening. You see, the vote was close to not going through. In patient without an obvious cause of stroke with a positive diagnosis of right-to-left shunt on initial assessment, we suggest TOE to gain additional information about the presence and the anatomy of the PFO, and the vote is 9 to 9. And I think this is common clinical practice, because then we delegate to our cardiologist to perform the closure, and they need to identify the morphology of the PFO. This is the supporting evidence for PICO 1:1. You see 1.1. You see this is the ROC curve. So absolutely no accuracy. Same for PICO 1 to 2, and 1 to 3. There's even no evidence. So I can tell you these words, where you have less evidence, the chapter is the more difficult. And this was the chapter that was mostly criticized by our reviewer, because to find, and when you have clear evidence, it's very easy to formulate evidence-based recommendation. PFO after stroke. The overarching question is which therapeutic strategy should be used. So, and the first question is, in patient with cryptogenic stroke and PFO, does percutaneous closure of PFO plus antiplatelet therapy as compared to antiplatelet therapy alone reduce the risk of stroke recurrence? These are our evidence-based recommendation in patient aged between 18 and 16, in whom no other cause, again PFO-associated stroke, for stroke is found. We recommend PFO closure in selected patient in addition to antiplatelet therapy. Quality of evidence high, and strength of recommendation strong for intervention. In patients aged 18 to 16 with possible or probable PFO-related stroke according to Pascal classification, we recommend PFO closure in addition to antiplatelet therapy. Quality of recommendation moderate, strength of recommendation strong for intervention. In patient between 18 and 60 with unlikely PFO-related stroke, according to Pascal classification, we suggest against PFO closure unless there is a high probability of clinical causality, and this will be. I will explain you later in the expert consensus later. And the quality of evidence is low and weak against recommendation. clearly, based on the current data based on the randomized trials, we could not give evidenced recommendation in patients older than 60 and younger than 18. But again, we performed an expert consensus, which I will show you now. Regarding patients, we encourage in patients older than 60, when you are lucky to live in a center where you have a randomized trial, and you know there's a French trial going on, to randomize these patients, or at least to register them in the registry, because we need the data. You saw the data already about patients over 60. We have a growing evidence that there can be a benefit in closing this PFO. So very important that we have this data in order to, when we update or when somebody else will update this guideline, that we have the data. We have some data, again, observational data, in patients below 13 and 17, and I can tell you, this is a challenge that we see more and more in our practice. I left the clinic with a 15-year-old boy having a stroke due to PFO. So, again, giving the lack of evidence this panel suggests PFO closure in patients aged between 13 and 17 with PFO-related stroke according to PFO anatomy. Timing, very important point, because this was a very good point from the reviewer. He reminds us about timing. We have no really data about timing. We know that it was within 6 months. The mean time from stroke to treatment was around 3 months. We recommend, in our expert consensus, we suggest that it should be done within the 6 months, but we know stroke is time dependent, secondary prevention is time dependent, so as soon as possible. And if you look also at the European Stroke Action Plan, again, there is a recommendation to close as soon as possible. What's about a patient who have an unlikely PFO-related stroke according to Pascal classification? In patients who have an unlikely PFO-related, so we suggest that there is a causality with when there is deep venous thrombosis, pulmonary embolism very close to index stroke, pulmonary hypertension, history of sleep apnea, or other hypoxemic condition associated with PFO. Valsalva at stroke onset, long-distance travel. Last case that we have now, a patient coming from Australia, 24-hour traveling, not business class, economy class, over 60 with PFO. Now we have to discuss what we shall do before sending him back to Australia. So we have the guidelines. We will be probably based on this. We will add him to a registry probably. And this is the supporting evidence done by, this analysis was done by Gulen-Turk. You see there's a clear evidence in favor of closure. Interesting, probably you will ask me why we didn't include TIA, because TIA we had only defense PFO included TIA patients. However, you will find a kind of justification that in stroke medicine, often TIA and stroke are considered an emergency in both, even if you don't have the lesion. So we could not do any kind of recommendation, but something that you keep in mind. This is the Pascal score, and you see the Pascal score is unlikely if you have a ROP score below 6, no large shunt, no aneurysm. Possible ROP score over 7, and large shunt or aneurysm. Probable RAP score over 7, large shunt or aneurysm, or both, which is the most frequent condition that we meet. Yes. PICO3 in patient with cryptogenic stroke and PFO, does percutaneous closure of PFO plus antiplatelet therapy compared to anticoagulation reduce the risk recurrence? There are insufficient evidence to recommend anticoagulation, so the quality of evidence is very low and weak for intervention. We have only one trial on this, the closed trial. So this is PICO3. PICO4 in patient with cryptogenic stroke and PFO, does anticoagulation compared with antiplatelet therapy reduce the risk of recurrent stroke? The evidence recommendation is clear. There's a continued uncertainty over the risk and benefit of the use of anticoagulation versus antiplatelet in patient in whom no other evident cause of stroke is found but a PFO. The level of evidence is low, and the strength of recommendation is not there. However, the panel suggests an individualized approach in the choice of antithrombotic therapy for patients with PFO-related stroke who refuse to undergo a PFO closure. The choice of anticoagulation over antiplatelet should be balanced. The expected lower risk of PFO-related stroke recurrence with a possible increase of long-term risk of major bleeding and taken into account patient's preference. Because I can tell you, sometimes I have a patient who did not close and I'm trying to make him stop anticoagulation. He's on warfarin and he feels safe and he doesn't want to stop, and this is his patient's preference, so you have to accept it. And this is the supporting evidence. Clearly no dedicated trial on this. We have the data from Navigate ASUS, Respect ASUS. None of this trial was designed to answer these PICO questions. Just here, I realized when I was checking the presentation that the evidence-based recommendations are not the right one. I will read them for you later. Don't ignore them, please. So the question is, after percutaneous closure in patient with PFO-related stroke, does dual antiplatelet therapy after the procedure compared with single antiplatelet therapy reduce the risk of recurrent stroke? Please ignore. So here the right formulation is, in patient undergoing PFO, we suggest dual antiplatelet therapy followed by single antiplatelet therapy to reduce the risk of recurrent stroke based on the protocol of the available randomized trial. The quality of evidence is low and the strength of the recommendation is weak against intervention. We cannot, second recommendation is no evidence-based recommendation can be formulated regarding the duration of the single antiplatelet treatment. And this is another still open question. So, in patients, the expert consensus is in patients with PFO-related stroke who underwent percutaneous closure, according to the protocol design, the majority of positive randomized control, the panel suggests to prescribe dual antiplatelet treatment for 1 to 6 months, followed by a single antiplatelet therapy in a long term for at least 5 years after intervention. 9 of 9 expert agrees. And you see, but these are observational studies and not randomized trials. PICO6, you know, one of the most important adverse events of PFO closure is atrial fibrillation. So the PICO-6, we focused only on atrial fibrillation, the screening of atrial fibrillation after PFO closure. As you know, there is already a guideline, an ESO guideline about screening of cryptogenic stroke, including atrial fibrillation screening done by Marta Rubeira and Maurizio Pascheroni, and we refer to this screening guideline, so we didn't want to do something else what was already published. And our evidence-based recommendations state as followed. In patients aged between 18 and 60, in whom no other cause of stroke is found but a PFO, there's a continued uncertainty over the risk and benefit of the use of long-term cardiac monitoring. Quality of evidence very low, strength of recommendation 0. So, very important point, because we don't know the importance, and this is something that we already, the late onset atrial fibrillation. When you look at the full publication, you will see that we gave a very low value of the late onset atrial fibrillation, because we do not really know how much these atrial fibrillation is related to the index stroke. And we know the paper from Luciano Sposato clearly state that this late onset atrial fibrillation has very low risk compared to atrial fibrillation before stroke. So again, and the paper that we detected on positioning loop recorder after PFO, we only found increased detection of atrial fibrillation, but not a reduction of stroke risk. This is something that you always have to keep in mind. However, again, and you will find this in the full publication, there are randomized trials going on about positioning and loop recorder after PFO closure. So we will see what comes out from this studies. The area of future research. I did not discuss about cardiac MRI and cardiac CT because we mentioned them in the text. However, there are no studies, but the future will show probably more and more important of cardiac CT and MRI. We still need a gold standard, so maybe this could be going ahead with all this new methodology. We will find a gold standard. Treatment. What happens with the PFO which started to talk or became symptomatic during pregnancy? We did not face this. Still, we have some uncertainties in PFO closures with lower than 18 and more than 60. What's about when we have a residual right to left shunt? There are some paper that it does not really increase the risk of recurrence. However, these are again observational data, so we need the data. What's about the duration of antiplatelet? Some patient, even after closure, stays for antiplatelet for 10, 20 years. So we really don't know if this is futile, harming, because we see from observational data that there are some bleeding complications, not brain bleeding, but gastroenteric bleeding and so on. Prognosis, systematic long-term monitoring after PFO closure, the causal role about late onset atrial fibrillation, and also this device detected AF. How much is this important in the pathogenesis of the stroke? So, this is our conclusion, close PFO in patient aged between 18 and 16, in addition to DAPT for up to 6 months, use Pascal classification for patient selection, and randomize patient over 60. Thank you.
Thank you very much, Valeria, and to all the working group members for the extensive work, for the comprehensive presentation. Is there any questions? I remind all of you that the simultaneous full publication in the European Stroke Journal can be accessed free. If not, I guess we can... There's a question. Yeah.
Thank you, Valeria. Fantastic work.
Thank you
Really good.
to the group.
Really challenge. I have two questions, actually. The first question is, while you're waiting for the PFO closure, just to be clear, you suggest DAPT, not NOAC.
For while waiting, what we do is now we start DAPT, yes, DAPT and not NOAC, yes, yes.
And the other question is, it sometimes happens that a patient with stroke it is discovered later on that there is a PFO. In other situations, we know that the risk is bigger to begin with, but with PFO, there has been suggested that the risk goes on and goes on. So if I have a patient who had a stroke, ischemic stroke, some years ago, and now the PFO is detected, what do you think about that?
That's a good question, because we discussed this many times also in our clinic. Think about the globally low risk of PFO, and the later, or the time which pass from the symptomatic being symptomatic, and the years, I don't consider this anymore. Because it's like think about symptomatic carotid stenosis. No, after 6 months, you don't consider it longer symptomatic. So it's something that I would see this in this direction. But the point is very important. This is a question that we will get many times, because they will maybe they didn't do it in a peripheral hospital. They do it after 1 year. They find a PFO. So what shall we do? This is a very good point. I tend not to close when there's much time from the event.
Yomi Ogun from Nigeria. Yeah, very nice presentation.
Thank you.
Yeah, just about the duration of DAPTs.
Yes.
Yeah, usually it's for 3 weeks and then converts to single antiplatelet. But this is 6 months. I mean, what's your comment as regards?
Yeah, that's based on the trial result, because one have 1 to 6 months. So we are only based on randomized data. So clearly, again, if you look at the data on how long, these are not a randomized choice. We didn't randomize for 1 month, 2 months, 3 months compared to 6 months. So again, we as you can see, for the DAP, we didn't give such a strong recommendation. We currently, what we see based on what we have from the randomized trial, it's 6 months after closure, and then followed by single antiplatelets.
Okay, thank you. I can see there are lots of other questions, but in the interest of time, we do need to move on. So let's thank Valeria again.